Good evening, everyone. I'm Dr. Lakshmipriya Menon from Aster Medcity, Kochi. And today I'll be talking to you about current airway management for thoracic surgery. So what is the relevance of my topic? Intraoperative aerosol generating procedures are unavoidable in the routine provision of thoracic anesthesia. Airway management for such patients during the COVID-19 pandemic include bag valve mask ventilation, tracheal intubation and tracheal tube repositioning, one lung ventilation and management of hypoxia, flexible bronchoscopy, and suction clearance of secretions. And these may pose a significant health risk to healthcare professionals and patients. Hence, there remains a need for timely thoracic surgery for patients with lung cancer or thoracic trauma in spite of the ongoing pandemic. The thoracic anesthesia community has been confronted with the need to modify existing techniques to maximize safety for patients and healthcare professionals. With appropriate modifications, aerosol generation may be mitigated against in most circumstances. So a set of practice-based recommendations for airway management in thoracic surgical patients was developed. And this is endorsed by the Association for Cardiothoracic Anesthesia and Critical Care and the Society for Cardiothoracic Surgery in Great Britain and Ireland. So what are the risks during the pandemic? Aerosol generation results from instrumentation of the respiratory tract, and SARS-CoV-2 appear in high concentrations in bronchoalveolar lavage fluid specimens and the sputum of infected individuals. Although the highest viral loads are encountered shortly after symptom onset, high viral loads are also found in the sputum of patients who are in the asymptomatic phase of their illness, highlighting the potential for transmission early in the disease course. So there are suggestions of increased severity of illness in those exposed to high viral loads, and aerosol generating procedures are a concern for those involved with airway management. I'm sure all of you in the last 1.5 years must have experienced scenarios where patient was COVID negative and you took them up for surgery. And in the immediate post-op period, either a bystander turns positive or the patient itself after routine testing in a few days ended up being positive. So COVID positive. So it's at times like these that our airway management skill keeps us safe. So coming to lung isolation during the pandemic. In its simplest form, lung isolation is the ventilation of the dependent lung while allowing the passive collapse of the non-dependent lung. The primary indication is to facilitate surgical access. It is a skilled and technical task that puts healthcare professionals at risk, as many steps involved in achieving and troubleshooting lung isolation generate aerosols. It can be provided by utilizing a single lumen tracheal tube alone, which is not usually a preferred technique, a single lumen tracheal tube with a bronchial blocker, or more commonly with a double lumen tracheal tube. So the problem with the just single lumen tracheal tube alone is that you will be going endobronchially and you have absolutely no access to the other lung. And single lumen tracheal tube with bronchial blocker is advantageous when, say, for a thoracic trauma case who's already intubated in the ICU, you shift them in for surgery. You don't need to do any more airway manipulation except bronchoscopically putting in the bronchial blocker. But with surgical manipulation, chance of slipping of the bronchial blocker and losing your lung isolation is high intraoperatively. So our most preferred technique always, if possible, is a double lumen tracheal tube. Now coming to tracheal intubation. The number of individuals present in theater during intubation should be minimized. The anesthesiologist, the airway assistant, and the theater assistant. And in our setting, the airway assistant is usually the anesthesia technician, and the theater assistant is either an OT technician or the circulating nurse. So the most experienced operator should plan and perform tracheal intubation, and the airway plan should be discussed at the team brief. Available equipment should include laryngoscopes, bougies, an appropriately sized single and double lumen tube, together with alternative sizes available from clean areas, 2 clamps, an additional HEPA viral filter, and a stethoscope. Viral and bacterial filters, which are frequently combined with heat and moisture exchangers, such as the HEPA filter, may be utilized to reduce the transmission of microbes between patients by preventing colonization of ventilators and breathing circuits. The patient should be adequately pre-oxygenated for 3 minutes or until the end-tidal oxygenation fraction is greater than 0.9. I said end-tidal oxygenation fraction, not the saturation. Okay. So the aim is to achieve sufficient apneic time to allow safe intubation without the need for bag valve mask ventilation and avoid aerosolization. The anesthetic technique should be a modified rapid sequence tracheal intubation using high-dose rocuronium. Face mask ventilation should be avoided where possible, and a 2% technique should be used where necessary. Tracheal intubation should be followed immediately by cuff inflation, circuit connection, and ventilation of both lungs in that order. Routine confirmation of positioning of double lumen tubes involves the use of a flexible bronchoscope to visualize directly the endobronchial cuff, which looks like a blue rim, and its relation to the carina. Following tracheal intubation with the left-sided double lumen tube, clinical confirmation should start with no clamp applied and bilateral air entry confirmed with manual ventilation. Once it is achieved, a clamp should be applied to the angle piece supplying the tracheal lumen. If this double lumen tube is positioned correctly, there should be left-sided air entry only. And vice versa is repeated with clamping the angle piece of the bronchial lumen and hearing right-sided air entry. Once the tracheal tube is placed correctly, the patient should be positioned for surgery. This checking process should be repeated after positioning laterally to ensure the tracheal tube position has not changed. During the COVID-19 pandemic, it may appear advantageous to avoid the aerosol generating potential of bronchoscopy in favor of clinical confirmation. But the disadvantage of this technique of clinical confirmation is poor sensitivity and specificity. So a bronchoscopic study involving clinical confirmation of DLTs by the intubating anesthesiologist found that up to 39.5% were malpositioned. If clinical confirmation of DLT position is used, bronchoscopy has to be available as it's not foolproof. Coming to flexible bronchoscopy. So the patient should be pre-oxygenated and the flexible bronchoscope prepared and ready for immediate use. The risk of aerosol generation will be extremely high if attempts are made to perform bronchoscopy while ventilating the patient or if the patient has inadequate neuromuscular blockade. Deep neuromuscular blockade should be confirmed by the use of a peripheral nerve stimulator. The adjustable pressure limiting valve or APL valve should be open and ventilation should be discontinued. After these steps are followed, here's a pictorial representation of what you should be doing. First, you clamp the angle piece of the tracheal lumen, followed by a second clamp over the tracheal lumen itself, as seen in figure A. Then you disconnect the angle piece from the tracheal lumen, as seen in B. Diagram C shows that after this, you have to apply the HEPA filter to the tracheal lumen, and only after that should the clamp be removed, as seen in D. So this will release the positive pressure in the lung. So after the lung has been deflated safely, you can remove the HEPA filter and start your bronchoscopy. The bronchial cuff can then be inflated under direct vision. Like I said, look for the blue rim right at the tip of the left mainstem bronchus. The angle piece can be reconnected and the remaining clamp removed to ventilate both lungs. This process can be repeated on the bronchial lumen as well to allow bronchoscopic confirmation that the distal end of the bronchial lumen is above the left main bronchus bifurcation. Once the patient is positioned for surgery, the process should be repeated to ensure satisfactory placement. And once bronchoscopy is completed, the bronchoscope should be placed in its designated area and used only by a single operator. Following each use, the operator should dispose of their outer gloves and perform hand hygiene. Next, I'll come to an example of troubleshooting tracheal tube malposition. Before that, let me do a quick recap of our tracheobronchial anatomy. As we all know, the trachea divides into the right and left mainstream bronchi, and the right main bronchus is less angulated and shorter with a length of 2 to 2.5 centimeter. And the left main bronchus is much longer with 5 centimeter length and is much more angulated. So it's very natural that a tube being inserted, if it goes endobronchially, has a tendency to go into the right main bronchus. Besides this, the right main bronchus divides into upper lobe first, and then the bronchus intermedius, which follows, divides into middle and lower lobes, whereas the left mainstem bronchus divides only into 2 upper and lower lobes. This can be remembered by remembering that the heart is on the left side, so there are just 2 lobes on the left lung. So following tracheal intubation, a left-sided DLT may be placed accidentally in the right main bronchus, just like for a single lumen tube. So this is estimated to occur in only 4.2% of cases, with an increased likelihood in shorter patients, women, and when using smaller sized DLTs. This is best managed with expedient bronchoscopy, as it will ensure the double lumen tube is placed in the correct position while minimizing aerosol generation and contamination. While troubleshooting, the tracheal cuff should remain inflated throughout to ensure there is no leak while the tracheal tube is manipulated. So this is opposed to common practice. And leaving the tracheal cuff inflated will also serve as a brake at the level of the vocal cords to minimize the risk of accidental extubation. First, the bronchial cuff should be deflated, and the bronchial lumen and arm of the angle piece connected to the bronchial lumen should be clamped. Repeat procedure of unclamping as before with the HEPA filter, and then insert the bronchoscope to the distal end of the bronchial lumen. This should reveal the terminal bifurcation of the bronchus intermedius into the right, middle, and lower lobe bronchi, as I mentioned before in the anatomy. So the double lumen tube can be withdrawn under direct bronchoscopic vision until the carina is visible and the bronchoscope is guided down the left main bronchus. In this scenario, the tube would have already bypassed the upper lobe. So you might even visualize that as you withdraw the tube. The double lumen tube is railroaded over the bronchoscope, and the distal end of the bronchial lumen is confirmed to be above the upper and lower lobe bifurcation. The bronchoscope is withdrawn, angle piece is reconnected, the clamp removed, and positive pressure ventilation is resumed. So bilateral ventilation should be confirmed before using the previous steps for safe bronchoscopy to visualize the right side again and to confirm correct double lumen tube placement and inflation of the bronchial cuff in the left mainstem bronchus under direct vision. Now coming to double lumen tubes with an integrated camera. So this is an advancement which is very useful during the pandemic where you don't have to do multiple bronchoscopies intraoperatively. So these are DLTs with an embedded light source and camera and have been developed to provide continuous monitoring of DLT position relative to the carina. Once correctly sighted, they may reduce the incidence of bronchoscopy for DLT adjustments and the risk of exposure during lung isolation. A bronchoscope may still be required if excessive secretions are encountered or if visualization is required to aid surgical progress. For example, if there is anatomic variation. The principles of minimizing the risk from aerosol generation during lung isolation are the same as for the standard DLT. So this is the diagram of the DLT with integrated camera. As you can see, it's connected to a monitor like the bronchoscope. And the extra parts as seen in the close-up picture are you have a light source and camera at the end of the tracheal cuff and the tracheal lumen. You have a camera connector to visualize the carina intraoperatively. And you have a port for flushing the camera lens. So this port can be flushed with either air or saline. Now coming to management of hypoxia during one lung ventilation. So it is during emergencies like this that our techniques tend to go haywire and we end up risking ourselves with aerosolization. So remember the methods during such situations as well. So the simplest method normally of administering oxygen for the operative lung is via insufflation through a suction catheter through the open lumen of the double lumen tube. This but carries an unacceptable risk of aerosol generation. So instead, the method recommended involves use of a continuous positive airway pressure circuit, the CPAP circuit as shown here in the figure, with a HEPA viral filter. As with normal practice, continuous CPAP should be titrated until there is clinical improvement. So you can start at 3 centimeters of water and titrate up to 5 or 6, depending on improvements in oxygenation. Coming to finally tracheal extubation, which is the most important part, considering that there is no neuromuscular blockade and patient will have a tendency to cough and you are most exposed during this time. So in the rare situation that you do an extubation on table for a lung case, deep extubation may be considered to decrease the risk of aerosol generation with only essential staff present in theatre. Oropharyngeal and bronchial suction should be performed before the reversal of neuromuscular blockade and avoided at the point of extubation, as this can precipitate coughing. The patient should be positioned in an upright position on a bed or trolley with full reversal of neuromuscular blockade confirmed with nerve stimulator. They should be breathing spontaneously with no pressure support and with the adjusting pressure limiting valve open. A clinical waste bin should be placed beside the patient for immediate disposal of the removed tracheal tube. The circuit should be disconnected, leaving the HEPA viral filter, an angle piece attached to the tracheal tube. So in a sense, like a T-piece. A Hudson mask should be applied immediately and apply a surgical face mask over this Hudson mask. This will cover the entrainment vents on the mask and reduce the risk of contamination from coughing. Wait for 20 minutes following extubation before transferring the patient from the operating theatre. Mostly for thoracic cases, what is preferred is that under full neuromuscular blockade to remove the DLT and insert a single lumen tube, or in the case of a bronchial blocker, just remove the bronchial blocker and shift the patient to ICU, but follow these same techniques to avoid too much aerosolization during extubation in the ICU as well. The applying the surgical face mask over the Hudson mask or the O2 mask is also to be remembered in case of coughing from the patient side. So to summarize, the final recommendations are: efforts should be made to minimize the number of staff present in theatre for aerosol generating procedures, limiting it to a minimum of 3. Pre-oxygenation to achieve an end-tidal expired oxygen concentration of more than 90% should be undertaken before all airway interventions. All airway interventions should be carried out after ensuring adequate neuromuscular blockade as assessed with a peripheral nerve stimulator. Positive pressure within the breathing circuit should be released by opening the adjustable pressure limiting valve and discontinuing positive pressure ventilation before all airway interventions. The risk of aerosol generation when opening a double lumen tube to the atmosphere can be mitigated against by using appropriately placed HEPA viral filter and clamps. The DLT should only be open to the atmosphere after allowing release of positive pressure within the lung through a HEPA viral filter. And finally, flexible bronchoscopes can pose significant contamination and cross-infection risks and should be stored in a designated area during the case. Following use, the outer set of gloves worn by the operator should be disposed of and hand hygiene performed. So to conclude, the management of thoracic surgical patients during the COVID-19 pandemic requires modifications to normal practice. And this is irrespective of a COVID case. This is for any case. The risk from aerosol generating procedures must be reduced wherever possible to ensure the safety of patients and healthcare staff. These are the clinical practice recommendations for techniques which will limit the potential for aerosol generation associated with lung isolation and thoracic surgery. And we have to go through the techniques of clamping, unclamping, adding the HEPA filter, and letting the positive pressure of the lung be released repeatedly in our mind so that it becomes a system for us, so that even in cases of emergencies like hypoxia on one lung ventilation, we follow the same techniques. And our airway management is safer for our sake and the patient's sake. These are my references. Thank you for your patient hearing. Hope this was useful.